Medicine Grand Rounds. Before I introduce today's speaker, I have some housekeeping items to review. This CME activity is jointly provided by the Queen's Medical Center and UH-JABSOM Department of Geriatric Medicine. As a reminder, evaluations are required for CMEs. You can find the evaluation form by following the link in the chat at the end of this talk, or in our email advertisement, or on our website. Your comments are very important to the planning committee and will be used to plan future programs. All speakers are asked about potential conflicts of interest. Today's speaker does have associations with commercial enterprises, and these are disclosed on his second slide. It is my great pleasure to introduce today's speaker. Dr. Stephen Chun is a radiation oncologist practicing at the MD Anderson Proton Center and West Houston campus.
You're muted.
Yeah, can you guys hear me?
Okay, I got muted. Okay.
Yeah, she got muted.
Somebody muted me. Okay, I'm going to go back. Dr.
Okay.
Stephen Chun is a radiation oncologist practicing at the MD Anderson Proton Center and West Houston campus, co-host of the NRG Oncology podcast, and vice chair of NRG Oncology Protocol Operations Management. As director of radiation oncology clinical research for the MD Anderson Houston area locations, he led the expansion of the radiation oncology clinical trial program across the MD Anderson Integrated Academic Satellite Network. He is supported by extramural grant funding from the NIH as principal investigator. In the MD Anderson Houston area locations, he implemented the stereotactic body radiotherapy SBRT program for pancreatic cancer, as well as the frameless stereotactic radiosurgery or SRS program for brain mets. As an active clinical researcher, he has published in journals such as The Lancet, Journal of Clinical Oncology, Journal of Thoracic Oncology, and JAMA Oncology. Dr. Chun is also a JABSOM grad, and we are so happy to bring him home and so happy and proud of all that he has accomplished. Please join me in welcoming Dr. Stephen Chun.
Well, thank you so much, Dr. Masaki, and actually Dr. Okamoto for having me. I'm really happy to see so many old friends and faces. I see Dr. Blanchette and Dr. Morai, Dr. Masaki, for those of you who didn't know, was a friend and a mentor to me. Actually, I'll never forget her recommendation to me. She said, and I believe she got this from Dr. Blanchette, always maximize your mileage. And that has served me well, I think, in the couple of decades since I've left JABSOM. And so today, I'm going to try my best not to be too technical. I know this is the Department of Geriatrics, so I don't want to get too much into the technical or esoteric details about the management of lung cancer, but I really want to focus on how do we manage these lung cancer patients who are frail and elderly, which is probably, I would argue, the majority of lung cancer patients. And so these are my disclosures. None of them are really pertinent to this talk. And I think it's informative to, we see Dr. Yamada here too, an old friend and mentor. I think it's informative to go back through my medical journey. When I started off at the University of Hawaii back in 2005, the big flood had just destroyed the biomedical campus, and we in a frantic way moved into the Kakaako campus. Ed Cadman was the dean, and Sam Shoemaker was the vice dean, and now Sam Shoemaker's the dean again. He actually gave me my white coat when I was a first-year medical student because Dr. Cadman just stepped down. And if we go back to 2005, I'm so glad Dr. Yamada's on the call. My first encounter with lung cancer, this is a Kagami Ulua I actually shot in 2005 when I was a medical student. Dr. Yamada was my PBL tutor, along with Dr. Cadman. And one of the cases, which perhaps is still used for PBL, was Edna Ota. And I believe this was a case of, of small cell lung cancer, um, which we used problem-based learning to get through. And the focus was actually not so much on the science or the outcomes, but it was on breaking the news, the stages of grief, palliation, end-of-life considerations, and the humanistic side of lung cancer. And it's hard to believe that was 20 years ago at this point. And furthermore, some of my first experiences clinically with lung cancer 20 years ago were at the Queen's Medical Center Tumor Board, where some of the players involved Paul Morris, Dan Fishberg, Clayton Chong, who's no longer with us, and Paul DeMar. And a lot of the discussion back in 2005, 2006, even for non-metastatic lung cancer, was around, okay, do we even treat unresectable lung cancer or not, particularly in these frail and elderly patients? And what I hope today to convey to everyone here is that it is an entirely different world in 2026, now 20 years later. Um, and if we think back to 20 years ago, the unresectable lung cancer population, um, some people here know, I think Dr. Yamada might recall, I'm a big classical music fan. Leonard Bernstein, there he wrote West Side Story. You might have seen Maestro, the movie with that came out. You also had Dean Martin, Desi Arnaz, Peter Jennings, all had unresectable bad lung cancers and were dead within less than a year of their diagnosis. Um, Dean Martin opted not to even be treated. Leonard Bernstein was actually treated by one of my mentors at Memorial Sloan Kettering, 30 gray and 10 fractions, palliative radiation for squamous cell carcinoma. And we didn't have modern chemoradiation at the time. And again, survived maybe about 9 months. Peter Jennings, I think a lot of people here might remember, diagnosed with small cell lung cancer. Didn't survive more than 6 months. But when we think about this frail, inoperable population, what are the reasons that they're inoperable? First, they could be technically unresectable. If there has been either local, regional, or distance spread, surgery is just not appropriate. But then there are medical reasons for unresectability, inadequate pulmonary function, kidney function, if they've had a heart attack or some other coagulopathy and they're dependent on anticoagulation, you're not going to want to take them off of anticoagulation. Um, for surgery, performance status, if they're actively smoking 2 packs a day, and that puts them at a very high risk for surgical complication. And then I think importantly, patient refusal. Many of these patients don't want to undergo surgery because of social or other logistic issues. But I want to emphasize that to this day, lung cancer, I took this off of the American Cancer Society website. Lung cancer remains the leading cancer killer in both men and women in 2026. This has not changed in the last 20 years. About 800 people are diagnosed each year. And the majority of them are going to die from the disease, 5 of the 800 people. And so, even though I think most people on this call are not oncologists, um, we need your help. And I'll get into why and how we can all be part of the solution here. Pertinent to this audience, what does the USPSTF recommend? They recommend adults from the age of 50 through 80 who have a 20-pack year smoking history and are currently smoking or who have quit within the last 15 years undergo low-dose CT screening. I also want to point out that they recommend stopping screening if they haven't smoked for 15 years or there's a health problem that limits life expectancy or the ability to have lung surgery. And you might notice my red arrow is at the lung surgery. If I can make one point this entire talk, it's this caveat, ability to have lung surgery. That is out of date. That is no longer appropriate with the non-operative interventions we have for lung cancer. Um, I recognize that the trials that inform these recommendations were in an era that we didn't have anything other than surgery. But today we have excellent non-surgical options, and really anyone who is expected to live more than 2 to 3 years, um, a lung cancer-directed intervention will have a survival benefit. Now, why do I need everyone's help here? I again just took off the American Lung Association website. We are 50 out of 50. We are the worst here in Hawaii in the United States for early detection of lung cancer because we are one of the worst states in the United States in terms of actually doing the lung cancer screening appropriately. Um, 39 out of 51. And I recall seeing this data about 5 or 7 years ago when it first started coming out. And I always presumed things were going to improve, but um, uh, to this day, we still are faced with this issue. And I, I, I implore everyone on this call to for this to be a call to action. We can, we should do better. Um, what is reflected in these screening outcomes? Um, this is a study that I was principal investigator for a few years ago. I collaborated with Brenda Hernandez, who's at the University of Hawaii Cancer Center. John Lin and Shirley Lee, the co-first authors here, were my um, actually medical students I mentored first and co-first authors. Um, but when they started looking at the data, what this is the Hawaii Tumor Registry, what really jumped out at me was the median survival of metastatic lung cancer here in the Hawaiian Islands across the board. And we looked specifically at the different insurance statuses. If we looked at private insurance, median survival was only about 8 months. What should be typical of lung cancer is really a minimum of 12 months, but probably more like 2 to 3 years should be the median survival. What was even more stunning was that for Medicare patients and Medicaid patients, there was a median survival of only 4 to 6 months. And then at the bottom of the pack were VA insured patients who had a median survival no better than hospice, 2 to 3 months. Do I think that somehow we don't do chemotherapy or immune therapy here as well as other places? No, I don't. I think the main issue here is even amongst people with metastatic lung cancer, there's a difference between catching things early and catching things late. And this is highly suggestive. We're catching things really late. Um, and again, I think what we're seeing with the screening is manifesting itself in real time with the actual outcomes. And and again, we haven't seen a change uh, in the last 5 years or so, and I think it can be very easy here in Hawaii to say, Hakuna Matata or Hey, surf's up, whistle past the graveyard on an issue like this. But um, I've always looked up to people who have built the infrastructure here in Hawaii. This is Dr. Thomas Lau, born 98 years ago, actually in poverty, really complete poverty. First and only one of person in his family at the time to attend college, ended up doing real well, went to medical school, and actually single-handedly established the oncology endoscopy hospice programs here when none of that existed in the 1960s. I mean, imagine that daunting task. I mean, we're talking screening. Um, these were far more daunting tasks to take on. And as far as I know, he is the last surviving original faculty member of the medical school or the cancer center. And I was happy to do dinner with him last night because he's my grandfather. Um, I know that Dr. Blanchette was his medical student and trained under him, as well as perhaps some of the rest of you on the call. These are my kids. Um, Still has a good appetite, still has good dry jokes, like he used to tell at the St. Francis uh, staff parties. Um, and so, with all this in mind, I want to go through the management and outcomes for the state for lung cancer in these frail patients, in these inoperable patients. What can we offer them? What can we offer your patient who is perhaps in a wheelchair, but you would otherwise expect them to live the next 5 years? Um, and um, when we think about the evolution of non-operative management of lung cancer, I'll take us back to 2006. So let's go back to my picture. Think about in your head the picture of me with that big fish, with Ed Cadden, with Dr. Yamada here in 2005, 2006. How did we treat lung cancer at the time? We, in a very crude way, put postage stamps fields on a tumor like this. We shot radiation from in front, from behind, and the outcomes sucked. You look at the percent of people alive at 5 years. I mean, it is virtually, for two-dimensional radiation in the toilet, for 3D, similarly, you not more than 10 or 15% of people survived with an inoperable lung cancer back then. But I remember my cell phone. In fact, perhaps some of the people here will remember Jill O'Mori when she first had a grant to do Blackberries for medical student education. What did cell phones look like back then, and what do they look like now? Big difference. Um, The same is true of radiation and non-operative treatments of lung cancer. This is the linear accelerator around 2005. There was no onboard imaging. There was no volumetric arc therapy. There was no adaptive or radiotherapy to motion management. And perhaps this might even be an advanced linear accelerator for 2005. Fast forward to radiation today. We're talking about things like the Vero, where you have um, numerous degrees of freedom for unprecedented conformity, like your smartphone phone today. Things, I just have some represented machines. I'm not going to get into the technical details, but um, you've got radiosurgery, you've got particle therapy, all sorts of things. And this is part of why the outcomes have changed. And this is part of why the caveat in the USPSTF recommendations that the patient has to be a surgical candidate is not relevant. Well, perhaps it's relevant if we consider radiosurgery as a form of surgery. And if we're considering radiosurgery as a form of surgery, then I would argue that almost everyone is eligible. What have been some of these advances? We now have much more accurate staging with routine PET scans and MRIs. We are now using modern linear accelerators with high megavoltage energy, able to penetrate and kill these tumors. You see the picture there of a cobalt teletherapy source for one of the first children treated at Stanford for a retinoblastoma. I mean that, and it's hard to believe we did stuff like that. It makes me think of when Dr. McCoy went back in time in Star Trek 4 and chewed out the doctors at San Francisco General for using things like craniotomy and chemotherapy. But things have changed a lot. We can now manage motion and assess motion in 4 dimensions. Our technique is better than it's ever been. And even 20 years ago, this is RTOG 0236. This is what really revolutionized inoperable lung cancer management. These were early stage lung cancers. And instead of doing your postage stamps, we used something called stereotactic body radiotherapy with numerous degrees of freedom to bring in a biologically effective dose of over 100 gray to your tumor target. Um, so really massive dose on the tumor and negligible doses elsewhere. If you think about before this, we were irradiating more normal tissue than tumor. It was only in the early 2000s did we start irradiating more tumor than normal tissue. And lo and behold, 60% of the patients survived long term, and majority of them were cured. 70 to 80%. So again, I would argue these were all inoperable patients. I would argue that being able to take someone to the operating room or not is not relevant. It hasn't been relevant for 15 years now. Um, and here's some other outcomes. This is the pooled analysis of the ICE of the Rosal trial and the STARS trial, where they actually compared surgery and radiation in operative patients, randomized trial. Uh, there's some controversy behind this trial because behind the study rather, because these were two studies that didn't fully accrue and they combined them together, the same aims of the two studies. And interestingly, when they combined them, there was a survival benefit for radiation because there was no operative mortality with radiation. Again, controversial, but there's evidence here that non-operative management is probably at least equivalent to surgery. So again, USPSTF surgical verbiage is irrelevant and out of date. Um, Probably some of you are asking, well, can my patient who might be in a wheelchair or a walker, someone like my 98-year-old grandfather, can they tolerate stereotactic radiotherapy? Even back in 2002, the severe toxicity rate was only maybe 1 in 10 patients. Today, it's actually lower. Because the radiation technique has gotten better. So the answer is, yeah, most patients are going to tolerate this. And what's especially important here is, yes, there were things like severe pneumonitis and um, and 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 chest wall pain in a minority of patients, but there were no radiation-related deaths, and we cured the majority of patients. I want to move on next to locally advanced lung cancer. And what do I mean by locally advanced lung cancer? So we just spoke about early stage lung cancer without regional lymph node involvement. Okay, well, what's next when it's spread to regional lymph nodes in the lungs or the mediastinum? That's what I mean by locally advanced lung cancer, but no evidence of distant metastatic disease. And I mentioned Leonard Bernstein, Dean Martin earlier. Both of them had actually locally advanced lung cancers. And if you think about the late 80s, early 90s, these are all trials on the bottom that move the needle forward for locally advanced lung cancer. When they were treated, I think it was a legitimate conversation to say, okay, should we even treat them or not when we're not curing substantial numbers? So the median survival is on the y-axis, the trial, and basically the year is on the x-axis. In RTOG 8407, so 1984, trial number 7, you had a median survival radiation alone of about 9 months. Mid-90s, RTOG 9410, median survival about 17 months, so maybe a year and a half. Um, let's fast forward to RTOG 0324, probably reflective of when I was in medical school in 2005. So RT 0324, so it was in 2003. Median survival short of 2 years, about 2 years. And, when you had numbers like this, I think it was a totally legitimate conversation to have. Do we even offer treatment to these patients? And the long-term survival was probably no better than 10 or maybe 15%. Fast forward to the Pacific trial, 2015, 2018, and you now have a median survival, thanks to the introduction of immunotherapy, of close to 5 years. The world has changed in a huge way because of the advances in chemotherapy, radiation, immunotherapy. Um, I also want to point out here, if we go back 20 years ago to um, 2003. Again, this is about when I was in medical school. Even back then, they looked at whether chemoradiation had benefit in the elderly. This is an old study done by my friend Steve Shield. He's the chair emeritus of the Mayo Clinic. Um, and one of his landmark studies in 2003 was he looked at patients treated in this study of cisplatin and etoposide for locally advanced lung cancers. And by all measures, cisplatin and etoposide are primitive forms of chemotherapy that we do not generally give for locally advanced lung cancer anymore because they're too toxic. And we have other regimens that work just as well or better. Nevertheless, what was actually seen was no real detriment in the elderly patients over 70. They had just as much benefit from doing concurrent chemotherapy, even though there was more toxicity in the elderly. So again, we've known for some time that even the elderly who are non-operable can tolerate chemoradiation. Um, and I'm someone who's really against um, discriminating against people on the basis of age alone. I mean, it's one thing if you have serious medical comorbidities, but it's another thing to just throw in the towel because someone is elderly. Um, a more recent study that I've led, published in JAMA Oncology about a year and a half ago, looking at the largest contemporary study of locally advanced non-small cell lung cancer treated with chemoradiation. One of the fascinating things we saw in this study, I've highlighted that I actually looked. What is the impact of age on survival in the multivariable analysis? Age in of itself, once you adjusted for tumor stage with a dose of radiation, the size of the tumor, once you adjusted for all those things, actually, age alone was not a significant predictor of survival. And again, I think this makes sense. It's one thing if you've got a 50-year-old who has all kind of medical comorbidities and they're going to do bad. It's another thing you have. I'll share with you. I have actually treated a 92-year-old with a locally advanced esophageal cancer with chemoradiation and cured them because they walked in, they had a minimal medication list, minimal comorbidity. So I'm a big believer in being objective and not just looking at age alone. I spoke earlier about the immunotherapy revolution. What is immunotherapy? Immunotherapy, I'm not going to get into technical details here, but conceptually, I think of immunotherapy. These are antibodies that are blocking the tumor from inhibiting the immune cells. So the immune cells want to come in and kill the tumor cells, and the tumor cells have come up with a strategy putting up PDL1, putting up MHC1. Think of it as putting the foot on the brakes. So tumor cell wants to put the foot on the brakes of the immune system, puts up PDL1, puts up MHC1. Um, what do these immune checkpoint inhibitors do? They come in with their FC with their variable regions. They bind PDL1, and then with the FC regions, they're blocking this interaction. And that is how they are taking the foot off the brakes. This is not putting the foot on the gas pedal the immune system. This is taking the foot off the brakes. And this has been a revolution. This received the Nobel Prize, I believe in 2017. And I already mentioned the Pacific trial of chemoradiation plus a year of immunotherapy for unresectable, frail patients with locally advanced lung cancer. Again, we actually see a median survival 4 to 5 years, which is remarkable. Um, I want to also point out there's another kind of locally advanced lung cancer, small cell neuroendocrine. When I was in medical school, okay, there was bad lung cancer, non-small cell. There was really bad lung cancer, small cell. What's fascinating is this is the Adriatic trial that came out last year. If you look at the long-term survival, actually, for the first time in history, our limited stage small cell patients are living a year longer than the locally advanced non-small cell. Median survival here is about 5 years. We have never before seen a median survival of 50%, or a median survival of 5 years for a limited stage small cell before. Again, many of you are wondering, can they tolerate chemoradiation? This is analysis I did of 0617, published in the Journal of Clinical Oncology. And what I want to point out is that when using modern radiation, modern chemotherapy, this is just a table of severe grade 3 or higher toxicity events. Likelihood of severe pneumonitis, about 3.5%, esophagitis, 13%, weight loss, 4% cardiovascular, 5%. It is a minority of patients who actually have severe toxicity related to chemoradiation in this day and age. Probably no more than 15 to 20%. I'm not minimizing that we cause toxicity, but again, radiation machines, chemotherapy, just like a cell phone, are a lot different today than they were in 2005. Now, to put this in perspective, I showed the long-term survival of locally advanced lung cancer being about the median survival being about 4 or 5 years, limited stage small cell being about 5 years, maybe more. I want to put this in perspective. This is the clinical trial looking at CMF chemotherapy in 1995 in the New England Journal of Medicine. You're probably wondering, why is this guy showing us breast cancer studies from 1995? The point I'm making here is that finally, in 2026, we actually have survival curves that you could superimpose on these breast cancer survival curves for locally advanced breast cancer in the 1990s. And even in the 1990s, early 2000s, we would never tell a locally advanced breast cancer patient, hey, maybe you should just think about getting your affairs in order. Maybe we should just think about, no, we would offer treatment. We really have to get away from that stigma in lung cancer because we're seeing it's taken us 25, 30 years to get here, but we're seeing outcomes for locally advanced lung cancer, limited stage small cell that we were seeing for breast cancer 30 years ago. And I can only hope that in another 30 years, we're going to be seeing outcomes like we see for breast cancer now. Moving on to metastatic lung cancer, and I'm going to talk both about metastatic non-small cell and metastatic or extensive stage small cell. And just as we mentioned the revolution of immunotherapy for non-small cell lung, for locally advanced lung cancer, immunotherapy has been a revolution in metastatic lung cancer. So I recognize many patients who are elderly, who are marginal performance status, cannot get chemotherapy. Okay, that's okay. This is the original New England Journal article where they compared dual checkpoint inhibition with PD-1 immunotherapy and CTLA-4 ipilimumab for metastatic non-small cell lung cancer. And even here, the 2 year survival, 40%. What's even more striking here is you have a tail of survivors which you never saw with chemotherapy before. Chemotherapy, before immunotherapy, everyone was dead basically at 5 to 10 years. Look at the tail of survivors for Ipi-Nivo, about 30, 40% long-term survivors. And we don't know actually who they're going to be. Even when you look at the PD-L1 expression rate, I've had patients who have responded who have been PD-L1 negative. On the other one hand, I've had patients who have been PD-L1 positive who haven't responded. So kind of a prognostic marker, but PD-L1 is not a predictive biomarker either for non-small cell or small cell. And again, you have an elderly geriatric patient who you say, well, why should I even screen them? If I find a metastatic lung cancer, what will they even be able to do? You can do checkpoint immunotherapy on almost anybody. And again, I want to pit that against our outcomes here in Hawaii. So look at the Ipi-Nivo or just chemotherapy alone. Um, in the Hawaii Tumor Registry on the left and look at the outcomes of this study that I just spoke about. Um, Again, it's highly suggestive we're just catching these way too late and being too nihilistic about this. Now, for extensive stage small cell, what I mean by that is metastatic small cell. Um, Again, we now for the first time have a tail of survivors when adding immunotherapy to chemotherapy. This is the Caspian trial. There's also been Empower 133, but I just want to give one trial as an example. Again, you see a median survival about a year and a half, but again, the fascinating thing here is 1 in 5 patients, about 20%, you look at that curve with immunotherapy, are surviving long term. And this is true whether it's melanoma, whether it's lung cancer, whether it's any number of tumors that are immunoresponsive. So I would argue here, you have somebody even with extensive stage small cell who can't get chemotherapy, uh, they should see one cycle of immunotherapy before going to hospice because we don't know who this miraculous 1 in 5 are going to be. Um, And again, can my patient tolerate immunotherapy? Here's the data. Fewer than 1 in 10 patients have toxicity serious enough to stop immune therapy. Only 1% of patients will have a fatal side effect related to immunotherapy, probably even less in experienced centers. Um, but the important thing is to know that steroids um, can, you catch a bad side effect early. Almost every immune therapy related side effect can be stopped with dexamethasone, prednisone, you name it. And again, you're probably wondering, why am I putting this breast cancer data up here? Okay, this is 2003 when I was in medical school. Well, actually, 2 years before I was in medical school, but similar outcomes at the as when I was in medical school. This was when they incorporated dose-dense ACT chemotherapy, Adriamycin, uh, paclitaxel, for breast cancer. My point is, in the early 2000s, where you see the overall survival, 10 to 20% overall survival for metastatic breast cancer, actually, we're exceeding that now for metastatic non-small cell, and we're exceeding it for extensive stage small cell. And we never told these breast cancer patients back then, hey, just, throw in the towel, consider hospice. Even fairly elderly patients, we tried to do something, whether it be tamoxifen or other intervention. Um, I want to close the talk just with a few pearls about approaching or at least how I approach the frail and the elderly. And again, I don't mean to pontificate to anyone on this call, a number of mentors and people who I respect enormously, because I know all of you have a lot more experience than me with the elderly. But let me ask people. I'm curious, or you don't have to respond. Maybe just think in your head, what performance status would you assign Itzhak Perlman, who, because of childhood polio, is confined to a wheelchair? Or Franklin D. Roosevelt, who was running the country, or Charles Dutoit, a conductor who is doing a demanding guest conducting schedule at the age of 90, with entire symphonies memorized. Same thing with Itzhak Perlman. He has a grueling schedule, conducting, playing violin, physically demanding. I mean, maybe he can't walk, but what he does with his arms and his brain are incredibly demanding. What if you didn't know any of this about them? I mean, I think just looking at these, a lot of people would assign, they'd see the wheelchair, give a poor performance status, or just see the age of 90 and give, okay, this is ECOG 2, ECOG 3. I suspect, and I've seen this happen. Um, where in performance status does it say walker or wheelchair? I will share with you again. I talked about the 90-some-year-old I treated with chemo radiation for esophageal. I've treated patients in their 80s with chemoradiation, locally advanced lung cancer, and cured them. I I have I had a patient like Itzhak Perlman who, because of childhood polio, was confined to a wheelchair, and actually her outside oncologist was talking about hospice because he felt that the performance status was just not sufficient for chemoradiation. But when I really started having a conversation with her, and I said, okay, ECOG performance status, um, tell me, what are you doing around the house? And she's like, well, I cook, I garden, I I'm fully independent. I drive, I do my own laundry. Um, uh, and I looked at her medication list, minimal medications. Actually, this was not an ECOG performance status of 3. It was an ECOG performance of 0. So I really ask people to be objective and look and don't just eyeball it and somebody and say, oh, that I can eyeball it. It's an ECOG performance status of 2 or 3, or Karnofsky performance status of 50. Okay, that might be true in many cases, but I think it's important. Someone comes in with a walker, but okay, it's because of an old football injury. It has nothing to do with their current disease or something like that. Um, so again, age, walker, wheelchair alone in of themselves do not dictate performance status. I don't have to tell this to this audience, but what's even more helpful is probably the comprehensive geriatric assessment. Um, and so I return now to the USPSTF recommendations. I don't know why my red arrow moved, but I hope to have compelled you. All of these lung cancer studies I showed you have endpoints where they are designed to show a benefit to patients with a 2 to 3 year time point. Really, if you think someone's going to be alive 2 to 3 years from now, whether they can have surgery is irrelevant because we have good non-operative managements, radiosurgery, chemoradiation, um, even chemoimmunotherapy. It's much more nuanced. The American Society of Radiation Oncology, American Society of Clinical Oncology, we have been pressing real hard to get them to change these guidelines because we think it is confusing and we think it is counterproductive. And so, in summary, um, I'm calling on all of us here on this call. We can and we should do better with lung cancer screening. Let's not be considering surgical candidacy alone, whether we decide to operate, because there are good non-surgical options. Really, for anyone with a life expectancy over 3 years, oncologic interventions that I've talked about will benefit them because all of those trials were designed to show a benefit within that time frame. And objective, comprehensive geriatric assessments are relevant here. Um, in terms of the outcomes with non-metastatic lung cancer, majority, and by majority I mean over 60% with stage 1 to 3 lung cancer will survive long term with non-operative interventions. And even metastatic lung cancer, between 1 in 5 and 1 in 3 patients are going to survive long term now. We've had relatively rapid improvements because of immunotherapy and radiation technology. And in 2026, the conversations that I heard when I was a medical student about just should we consider hospice, should we just not treat, generally speaking, inappropriate. We should really, maybe it does end up being appropriate when looking deeply and considering in a nuanced way every patient. But the outcomes we're having for lung cancer are like breast cancer in the early 2000s, and we never did that for breast cancer in the early 2000s. And before going to hospice, I would argue the majority of patients, even who are very ill, we should consider at least one cycle of immunotherapy because it's generally well tolerated, and we don't know who that miraculous patient is going to be who has um, a pronounced long-term response. And so, in closing, if anyone wants to or needs to get in touch with me, this is my email. I also invite people, if they want, to follow me on Twitter or X. I lead the NRG Oncology podcast, which we talk a lot about these topics. And I'm happy to open things up for questions. I hope this has been useful to all of you.
Thank you so much, Stephen, for an excellent, very informative presentation. Thank you. Yes, we do have time for questions. We have anybody who wants to ask a question, please unmute yourself and go ahead and ask, or you can also type it in the chat. So either one is fine. Seiji?
Thank you so much, Stephen. Good to see you again. I have a question just about the USPSTF recommendation itself. So I see that the current lung cancer screening recommendation is from 2021, and that the previous one was from 2013. And the large trial by the National Lung Screening Trial Research Team that was published in New England in August of 2021, I think is a study on which the screening recommendation itself is based. And I must say that I think we did a journal club in family medicine about this trial, and if I recall correctly, I think the false positive rate of screening was something on the order of like 95%. That is to say, of 20 positives that you get from screening, and I suppose that I don't know if that would translate as lung rads. I guess it goes from like 1 to 4 these days. And so I'm not sure if a positive is necessarily a lung RADS 4, or if we're talking about even lung RADS 2 or 3, which generally lead to repeating the test in so many months. So I must say that I've always been a little skeptical of screening because of this high false positivity rate. But I did bring this up with Dr. Chen Wen-Seng, who is a member of our family medicine faculty. She's retired now, although she's younger than I am. And She said, yeah, well, false positive. I mean, when you get a positive, it doesn't necessarily mean that you're necessarily going after tissue. That that a lot of it is a lot of the false positives you just end up redoing the screening over time.
That's correct. It's that because those were low dose, low resolution CT scans, and a lot of the time, when a contrast enhanced high resolution CT is ordered of a diagnostic quality, radiologists will say, okay, that's no longer concerning, et cetera. But I think the other thing to keep in mind is, I mean, it was a positive trial, but it was conducted decades ago at this point, and even like the cell phone has changed. The CT scans have changed. I mean, when this started, I don't remember the exact year, but it was performed decades ago. Then it took decades for the data to mature. And so actually the radiologists, the actual CT scanners, certainly the digital interfaces are much, much better now. So it's very hard to interpret in 2026 when the technology has actually substantially advanced.
Yeah, I do see that the enrollment was from August of 2002 through April of 2004, although the study wasn't published until like 2011.
Oh, right, right. And back then, some centers even you would have been looking at your films, up on a light. I mean, it's very hard to interpret those false positives from 20 years ago.
But it's also a study that's not likely to be repeated at this point, correct?
That's correct. I don't think it's because it was positive, and I think the belief um from the NIH is that if anything, things have gotten better. There's no reason to think that the benefit would decrease in magnitude. The only belief one could reasonably have is with better technology, better resolution, better radiology experience, that the magnitude of benefit is greater. The false positives would be fewer.
Finally, if I can ask, I mean, do we care about the radiation exposure that people receive from screening, from low dose CT screening or mammography, or I
So,
mean,
we never want to expose people inappropriately to radiation. But I think, and I'm not saying this is a trivial amount of radiation, but in patients who are 50 or older, it's one thing a child who is going to live for a long time more predisposed to have a radiation stochastic effect. Um, these screening CTs, to my knowledge, um, have not been linked to second malignancies. We also have very robust experiences with pediatric patients now who have gotten actually whole lung irradiation. And we don't see a massive increase in second malignancies or pneumonitis. Um, Low dose CT scans, um, I don't remember off the top of my head, but I want to say it's something like 100 or 200 X-rays. And when you fly over the Pacific, the amount of radiation exposure you get is probably from cosmic radiation equivalent to about 5 X-rays.
so much.
Any other questions for Stephen? Any comments?
Thank you, Dr. Marai.
Thanks, Stephen. This was a great talk. Thanks for taking your time to present to us.
Well, thank you for having it. It's great to see so many old friends and mentors who encouraged me um, to go into, it was Ed Cadman who really said, hey, you should go into to oncology. It wasn't so much my grandfather, actually.
Well, please thank your grandfather for all he's done for our community and for you. And if there are no more questions, I want to remind everyone, thank you, John. John has put the evaluation link into the chat. Please remember that if you want CME, you do need to complete an evaluation form. Okay, we still have time for one last question if anybody has one. And if not, then thank you all and see you all next month for our next grand rounds. Stephen, thank you again very, very much.
Thanks so much for having me. Aloha, everyone.
Hello.